For many of you, resuscitating a newborn is an uncommon experience. Although 10% of babies need some help to breathe at birth, only 1% require extensive resuscitation. Prompt attention from skilled caregivers at the moment of birth has been shown to decrease death from asphyxia worldwide. This video will help you master a series of interventions that can improve outcome. The scenarios that follow illustrate the major techniques used in neonatal resuscitation. Every resuscitation includes rapid assessment of the newborn. Many babies require the initial steps of resuscitation: provide warmth, position and clear the airway, dry, stimulate, and reposition. Evaluation of respirations, heart rate, and color determine the need for additional intervention, including the use of supplemental oxygen. Some babies require more extensive resuscitation, such as positive pressure ventilation or endotracheal intubation. Only a few require chest compressions and epinephrine or volume administration. How do you determine whether a baby needs resuscitation? There are 4 questions you must answer in a rapid assessment of every infant. Is the baby term? Is the amniotic fluid clear? Is the baby breathing or crying? Is there good muscle tone? If you answer yes to all the rapid assessment questions, the baby can receive the initial steps of resuscitation as routine care without leaving the mother.
The baby,
just a little bit more.
baby's head's right there. Let me check. Let me see. Okay, yeah, we're in a good position.
Healthy labor and birth require teamwork among the mother, her support person, and the perinatal care providers.
Oh, here it comes.
Here it comes. I see the head. Okay, that's it. Now take a breath. Give me one more push, and we're going to get this baby delivered. That's it. Come on. Good. Good job. Here's your baby.
Oh, there it is.
Is it a boy or girl?
It's a girl.
Oh, it's a
girl.
It's a girl.
You did great.
Oh, I'm so
So
excited.
proud of you.
All right.
Oh, she's crying.
This baby looks really good.
I can hear her
Oh.
crying, honey.
The person responsible for the newborn observes respiration and color and palpates an umbilical
Great.
pulse.
She's
beautiful.
She is beautiful. She's starting to breathe nicely. She's starting to pink up a bit. We're coming up.
Remember, most babies are vigorous at birth. The role of medical personnel is to monitor and support normal transition, foster continuous contact between mother and infant, and initiate early breastfeeding. If you answer no to any of the rapid assessment questions, the infant requires the initial steps of resuscitation. When meconium is present in the amniotic fluid and the infant is not vigorous, you will need to clear the airway by tracheal suctioning. To determine whether the baby is vigorous, ask yourself, are there strong respiratory efforts? Is there good muscle tone? Is the heart rate greater than 100 beats per minute? If the answer to any of these questions is no, the infant needs endotracheal suction to clear the airway.
When the baby's lymph isn't crying, let's go ahead and intubate.
Okay.
If the baby is not vigorous, if respirations are depressed, tone is poor, or heart rate is less than 100 beats per minute, tracheal suction should be performed.
And then the tube.
The newborn should not be dried or stimulated first.
See the cords.
Suction is applied directly to the endotracheal tube as it is slowly withdrawn.
Don't see any meconium down there.
Let's go ahead and dry them off.
The initial steps are then completed with drying, stimulation, and removal of wet linen, followed by repositioning of the airway. Evaluation of respirations, heart rate, and color follows, with administration of free-flow oxygen if necessary for central cyanosis.
Heart rate's good. It's over 100. Just trying to make some good respiratory effort. That's 1 minute.
Go ahead and stimulate them a little bit.
Okay.
It's pinking up very
Yeah,
nicely.
it's definitely picking up.
Good cry.
This baby is still at risk for developing problems and requires observational care while with his mother.
Should we see how he does without the oxygen?
Right.
Looks good. He's a cute one. Should we wrap him up and give him to Mom?
Sounds good.
If an infant is apneic, gasping, persistently cyanotic despite free flow oxygen, or has a heart rate less than 100 following the initial steps of resuscitation, initiate positive pressure ventilation.
Okay, let's warm the baby. Suction the oropharynx and nose. Okay, let's take off this wet blanket.
All right.
Baby is not breathing.
The initial steps of resuscitation have been completed, and the infant is still not breathing. Ventilation is the single most important and most effective step in neonatal resuscitation. Heart rate is monitored as positive pressure ventilation begins because a rapid rise in heart rate is the best indicator that inflation pressures are adequate.
I feel like I have a good seal, but I'm not getting good air entry. And I resuction the oropharynx and nose.
If heart rate, color, and muscle tone are not improving, look for chest movement
Reposition the
and listen
airway.
for breath sounds.
There's a little higher pressure.
All of the questions about oxygen concentration have not been answered. The standard approach is to begin positive pressure ventilation with 100% oxygen.
Heart rate's coming up.
However, concentrations less than 100%, including room air, may be used.
No, I think we have everything under control now. The baby's heart rate's coming up.
Okay, thanks.
Thank you. Heart rate is around 120.
Okay, looks like the baby's breathing well. Turning more pink.
Okay.
And we have a good heart rate.
This infant who has received positive pressure ventilation will require
take away the
post-resuscitation care with ongoing evaluation and monitoring.
How about we have Dad come over to the warmer while we just make sure the baby's breathing okay?
That sounds good.
Chest compressions should be initiated if the heart rate is less than 60 beats per minute despite 30 seconds of effective positive pressure ventilation.
This is Andre, the pediatrician. I'm here to help take care of your baby along with my nurse and the rest of
The obstetrical and neonatal care providers have communicated prior to delivery about complications and anticipated problems and inform the parents of the plan of care.
Okay, this baby is not breathing. We're going to start bag mask ventilating. Could you assess heart rate, please?
Oh, heart rate's down. It's less than 60.
Okay. Could you call the nursery and tell them we need extra help? We're going to start chest compressions on the baby.
I'm starting chest compressions. 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in.
The two-thumb technique places the thumbs on the lower third of the sternum and supports the back with encircling fingers. Thumbs can be side by side or one over the other.
Okay, could you reassess heart rate?
2 and 3 and breathe in. It's still less than 60.
Okay, we're going to have to intubate this baby.
Okay.
During compressions, 30 breaths and 90 compressions per minute equal 120 events per minute. Compression depth is 1/3 the anterior-posterior diameter of the chest.
Okay, see the vocal cords? Tube is through the cords. Sell it.
When resuscitation starts with less than 100% oxygen, supplemental oxygen up to 100% should be administered if there is no appreciable improvement within 90 seconds following birth.
Oh, and the heart rate's coming up.
Good.
It's above 80.
It's above 80. Okay, well, we can hold off on compressions, and I'll just continue to ventilate the baby. Could you reassess heart rate?
Heart rate's over 100, and the baby's beginning to breathe on his own.
Good.
As you have seen in an earlier scenario, intubation may be needed for tracheal suctioning with meconium-stained fluid. You may also need to intubate if face mask ventilation is ineffective, if prolonged positive pressure ventilation is needed, to secure the airway and expand the lungs fully during chest compressions, or to administer medication directly into the trachea while IV access is being obtained.
Okay, baby's still apneic. I'm going to go ahead and bag mask ventilate. Okay.
Even when a baby is critically ill, it is important to follow the initial steps and initiate positive pressure ventilation. A person experienced in endotracheal intubation should be immediately available to assist at every delivery.
Moving good air bilaterally. We've got a good seal.
We're still seeing good chest movement, but
Heart rate feels low. It feels about 20, but
So I think we're going to need to start compressions.
okay. 1 and 2 and 3 and breathe. 1 and 2 and 3 and
Breathe in.
1 and 2 and 3 and
Breathe
breathe.
in.
1 and 2 and 3 and breathe.
Breathe in.
1 and 2 and 3 and breathe. 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 I think it's been about 30 seconds.
Breathe in.
I'm going to recheck.
Endotracheal intubation may be necessary when bag and mask ventilation is prolonged or ineffective, to better coordinate chest compressions with ventilation, or to administer epinephrine while venous access is established.
I think we're going to need to go ahead and intubate the baby.
Okay, yeah, heart rate's still about 20. 1 and 2
How
and
can
3
I help?
and
We're about ready to go ahead and intubate.
breathe in.
Okay.
1 and 2
Do you think we
and
can
3
get
and
equipment?
breathe in. 1 and 2 and 3 and
laryngoscope.
1 and 2 and 3
We have a
and breathe in.
3-5
1 and 2
endotracheal
and 3 and
Okay.
breathe in. 1 and 2 and 3 and breathe in.
Okay, hold
1 and
compressions.
2
We're going to
and
go
3
ahead
and breathe in.
and
Stabilize the head in a slightly extended position and deliver free flow oxygen. As you insert the laryngoscope, you can see the posterior wall of the hypopharynx. Elevate the laryngoscope slightly and you can see the epiglottis and glottis come into view. However, if you insert the laryngoscope deeper, you see the opening of the esophagus. If the laryngoscope is to the left or right of the midline, you can see only part of the glottis. Insert the laryngoscope to the proper depth in the midline, and the epiglottis comes into view, serving as your landmark. At that point, lift the blade of the laryngoscope upward and away so that the vocal cords come fully into view. Sometimes pressure over the larynx will help visualize the glottis. Insert the endotracheal tube through the vocal cords to the appropriate guideline. Remove the laryngoscope while holding the tube firmly against the palate.
Gonna ventilate?
I'm seeing good chest movement. I'm seeing good
The primary signs of correct endotracheal tube placement are increasing heart rate and color change in a CO2 detector. The entire procedure ideally should take no longer than 20 seconds.
It's still low. Okay, let's resume chest compressions. Okay. 1 and 2 and 3 and 3.
The laryngeal mask airway is an alternative to provide positive pressure ventilation when bag and mask ventilation is unsuccessful or intubation is not possible. First, inspect the device and test the mask by inflating it with 4 mL of air. Then remove the air completely. Position the baby's head in the sniffing position. Hold the device like a pen with your index finger at the junction of the cuff and the tube. Open the baby's mouth and press the tip of the mask upward against the palate with the index finger, making sure the mask does not curl backwards on itself. Advance the mask into the hypopharynx until resistance is felt when the opening covers the larynx. Stabilize the tube with the free hand while removing the index finger. Inflate the mask with 2 to 4 mL of air to achieve a seal. Do not hold the tube during inflation, as the device may move slightly outward. Attach the resuscitation bag and begin positive pressure ventilation to confirm placement. An end-tidal carbon dioxide detector can be used, and the laryngeal mask airway can be secured with tape or another securing device. The airway may be removed electively after deflating the balloon, or the baby may cough it out spontaneously. If the heart rate remains below 60 beats per minute, despite ventilation with 100% oxygen and coordinated chest compressions, you should administer epinephrine. You also need to assess the possibility of hypovolemia and give volume if necessary.
2 and 3 and 3. 1 and 2 and 3 and 3.
When the heart rate remains below 60 beats per minute, despite 30 seconds of assisted ventilation, followed by another 30 seconds of coordinated chest compressions and ventilations, epinephrine should be given by umbilical vein.
Okay, Dr. Lee, I think we're going to need to put in a UVC. So if you would take what we're holding it, you look at that ready. 1 and 2 and 3 and 3 and 3. 1 and 2 and 3 and 3. It looks to me like this baby weighs about 3 kilos. Would you agree?
Sounds about right.
Okay. Circulator, we're going to need to drop some epinephrine. So we need epinephrine 1 to 10,000 concentration. We're going to need to drop 2 doses. One for the ET tube. That will be in a 3 milliliter syringe. I want you to drop 3 milliliters of epinephrine, 1 to 10,000. And then for the UVC, I want you to drop...
Although the endotracheal route is more accessible and faster than placing an umbilical line, the endotracheal absorption of epinephrine is variable. A dose of 0.3 to 1 milliliter per kilogram of 1 to 10,000 solution may be administered endotracheally if umbilical venous access has not yet been established. Deliver the medication directly into the tube opening rather than the adapter.
Should I reassess?
2 different routes and 2 different doses present a risk for medication error. Be certain that syringes are labeled and medication administered correctly. To insert an umbilical venous catheter, first place an umbilical tape around the base of the cord.
I hear good breath sounds on the right. I see good chest movement. Continue
Okay,
with
we'll continue
compressions.
compressions.
1 and 2 and 3 and 1 and 2 and 3 and...
Clean the cord with antiseptic solution and cut it with a scalpel 1 to 2 centimeters above the skin line.
Okay, I'm going to cut the cord and hold the compressions for a moment.
Okay.
Okay, resume compressions.
1 and 2 and 3 and breathe in. 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 1 and 2 and 3 and 1 and 2 and 3 and breathe in. 1 and 2 and 3 and breathe in. 1 and 2 and
Insert a pre-flushed catheter into the vein at an upward angle just until good blood return is obtained.
3 and breathe in. 1 and 2 and 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 3 and
A dose of 0.1 to 0.3 milliliters per kilogram of epinephrine 1 to 10,000 solution should be given rapidly and followed with normal saline flush.
1 to 10,000. 1 and 2 and 3 and breathe in. 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 1 and 2 and 3 and breathe in.
Okay, can we resusc?
Volume expansion should be considered if the baby is not responding to resuscitation and appears to be in shock from potential fetal blood loss.
Good breath sounds on the left. Good breath sounds on the right. I'm seeing good chest movement. You stop bagging for a moment. Heart rate is still below 60.
Okay, I think we're going to need to go ahead and give volume. Can you resume chest compressions? We're going to need 30 mLs of normal saline, please.
Normal saline or Ringer's lactate should be given in a dose of 10 milliliters per kilogram over 5 to 10 minutes via umbilical vein. For large volume blood loss, ORH negative packed red blood cells may be indicated.
1 and 2 and 3 and 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 breathing. 1 and 2 and 3 and
It's about half in.
Breathing on her a little bit.
It's like starting to make some effort.
Okay.
Let's go ahead and reassess hers.
Looks like she's starting to pink up just a little bit as well. Okay, listen for heart rate. Heart rate's in the 80s.
Good, we can hold compressions.
Okay, let me just, still moving good air on the left. Good breath sounds on the right. Still see good chest movement. Yeah, the baby's definitely pinking up.
Okay, let's continue with ventilation.
Okay, continue to dry her off too.
Check the heart rate once more.
Oh, heart rate's over 100.
Okay.
Yeah, over 100.
All right, let's prepare to go ahead and take the baby back to the nursery.
To prepare an umbilical venous catheter for emergency medication administration, flush the catheter in three-way stopcock with normal saline. Close the stopcock to the catheter to prevent fluid loss and air entry. Prepare the skin and cord with antiseptic solution. Place an umbilical tie around the base of the cord. Pause compressions and cut the umbilical cord with sterile technique. Identify the umbilical vein as the largest of 3 vessels, usually located between 11 and 12 o'clock. Insert the umbilical catheter a short distance and open the stopcock. Advance the catheter while aspirating gently just until blood return is obtained. The insertion depth usually will be 2 to 4 centimeters. Hold the catheter in place as you resume compressions, clear the line and stopcock of any air, and administer epinephrine or volume expander. The principles of neonatal resuscitation also apply to babies who require resuscitation beyond the immediate newborn period or outside the delivery room.
Oh, nurse? 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 Doctor? Anybody? Why aren't you breathing? Oh, I don't know what's wrong.
I'm gonna need to take this baby over to the warmer.
Oh, why? Oh,
How can I help?
I found him apneic in the bassinet, and I just started ventilating. Could you hook me up to oxygen?
Sure.
Ventilation is the priority for resuscitating babies at any time during the newborn period. A self-inflating bag should be available for emergency use. Positive pressure ventilation can be initiated with room air if necessary.
I hear good breath sounds bilaterally. There's good chest movement. The heart rate is about 30. I'll start chest compressions.
Okay.
1 and 2 and 3 and breathe. 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 2 and 3 and breathe. 1 and 2 and 3 and breathe. 1 and 2 and 3 and breathe. I'll reassess. Keep ventilating. I still hear good breath sounds. There's good chest movement. The heart rate is about 40. I'll resume chest compressions. 1 and 2 and 3 and breathe. 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 1 and 2 and 3 and breathe.
I heard a code called. What happened?
Hi, Dr. Daniels. I found him apneic in the bassinet. We just started CPR. I've been doing it for a couple minutes here, but his heart rate's still low.
Okay.
Breathe.
If you could hold compressions for a minute. Yeah, his heart rate's still about 40. I'm going to have to intubate, okay?
Okay. I'll decompress the stomach with an OG.
Insert an 8 French oral gastric tube if a newborn requires positive pressure ventilation with a mask for longer than several minutes.
You don't have to move. Keep ventilating. I'm going to estimate the nasal bridge to the earlobe to halfway between the xiphoid process and the umbilicus. I'm going to place the OG tube. Resume chest compressions. 1 and 2 and 3 and breathe. 1 and 2 and 3.